Imagine calling two hospitals in the same city. Same procedure. Same diagnosis. Same insurance. One hospital charges $8,000, another charges $28,000. And both are completely legal. Healthcare pricing doesn't just vary slightly. It can vary by hundreds or even thousands of percent. So why does the exact same medical care cost dramatically different amounts depending on where you go? Today, we're going to explain why hospital prices aren't standardized and why they were never designed to be. In most industries, prices are predictable. Gas stations post prices openly. Restaurants list menus. Retail stores compete visibly. Consumers compare options. Competition pushes prices toward consistency. But healthcare works differently. Most patients don't shop for care the way they shop for products. Medical decisions often happen, urgently, emotionally, with limited information, and under physician direction, which means traditional price competition rarely functions. Hospitals operate in a market where price transparency historically mattered less than availability and reputation. And that changed how pricing evolved. Here's something surprising. Hospitals don't actually have a single price for most services. They maintain something called a charge master. This is essentially a massive internal price list containing tens of thousands of billable items. Every medication, every supply, every procedure, every room charge. But almost nobody pays those listed prices. Instead, different payers negotiate entirely different rates, meaning insurance company A pays one price, insurance company B pays another, and Medicare pays something else. Uninsured patients may see the full listed charge first. So when you hear that hospitals charge different amounts, it's often because they are charging different negotiated prices simultaneously. Healthcare pricing is heavily shaped by negotiation strength. Large insurance companies represent millions of patients. That gives them leverage. They can negotiate lower reimbursement rates because hospitals want access to their network. But smaller insurers may lack that bargaining power. And out-of-network situations change pricing entirely. Hospitals must balance attracting insured patients, maintaining financial stability, and covering operational costs. Negotiations become complex financial agreements rather than simple pricing decisions. But this is where healthcare pricing becomes even more unusual. Two hospitals with identical medical quality may receive completely different payments for the same service depending on negotiated contracts. Price differences often reflect bargaining dynamics, not clinical differences. But there's another reason hospital prices look so inconsistent. The number you see on a bill is often not the number the hospital expects to receive. Hospitals publish extremely high list prices in their internal pricing system. These prices act more like starting points than final amounts. Insurance companies negotiate large discounts off those numbers. Government programs like Medicare use entirely different reimbursement formulas. And uninsured patients may initially see the full listed price before financial adjustments are applied. This layered pricing system evolved over decades of negotiation between hospitals, insurers, and regulators. What appears to be one price is often several different pricing systems operating at the same time. From the outside, it feels arbitrary. From inside the system, it's a complicated financial balancing act. Location matters more than most people realize. In regions with many competing hospitals, prices tend to stabilize. Competition pressures pricing. But in areas with limited hospital access, especially rural or consolidated markets, hospitals may face little direct competition. Over time, mergers and healthcare system expansion have created large regional networks. When fewer systems dominate a region, pricing flexibility increases. Hospitals also vary in mission. Community hospitals, academic medical centers, and specialty referral centers. Teaching hospitals, for example, often carry additional costs related to research and physician training. Those institutional differences influence pricing structures. Not all hospital services generate equal revenue. Emergency departments often lose money. Trauma care is expensive to maintain. Certain complex treatments require enormous resources. Hospitals frequently offset losses in some areas with higher pricing in others. This is known as cross-subsidization. Profitable services help sustain essential but financially challenging ones. So pricing differences sometimes reflect how hospitals distribute financial risk across their entire service line. You're not just paying for one procedure. You're contributing to the sustainability of the broader system. Another hidden force shaping hospital prices is the emergency department. Hospitals in the United States are legally required to provide emergency treatment regardless of a patient's ability to pay. This law ensures access to life-saving care. But it also means hospitals regularly provide treatment that may never be fully reimbursed. Uncompensated emergency care can represent a significant financial burden. Hospitals absorb these losses and redistribute them across other services. In practical terms, some of the cost of your scheduled procedure may also support the hospital's ability to treat emergencies for anyone who arrives. This obligation adds another layer of complexity to how hospitals price routine care. Price can also function as a signal. Some hospitals invest heavily in advanced technology, specialized staff, research programs, and nationally ranked services. Higher pricing may reflect branding, perceived expertise, or referral demand. Patients and physicians often associate higher cost with higher capability, even when outcomes are similar. Healthcare markets include reputation economics, not just operational cost. Now layer in billing complexity. Hospitals must manage hundreds of insurance contracts simultaneously. Each contract includes reimbursement formulas, bundled payments, quality incentives, and penalty structures. Billing departments translate clinical care into coded financial claims. Small variations in documentation or contract terms can alter reimbursement significantly. Administrative systems become essential simply to navigate payment rules. And administrative cost variability contributes to price variability. So, why are healthcare prices different at every hospital? Because healthcare pricing wasn't built like retail pricing. It evolved from negotiation, regulation, readiness requirements, and institutional differences layered over decades. There is no single national price setter, no universal market comparison. Instead, pricing reflects negotiated contracts, local competition, institutional mission, payer mix, and operational risk. What looks chaotic from the outside is actually the result of many independent systems interacting at once. In recent years, policymakers have pushed hospitals to make prices more transparent. The idea seems simple. If patients can see prices, competition should reduce costs. But implementing transparency has proven difficult. Because the real price for a service often depends on insurance contracts, negotiated discounts, and individual patient factors. A hospital may have dozens of different reimbursement rates for the exact same procedure. Publishing one number doesn't fully represent the complexity of those agreements. Even when price lists are made public, interpreting them requires understanding the financial relationships behind the scenes. Transparency can improve awareness, but it doesn't automatically simplify a system built on negotiation and layered payment structures. Healthcare pricing feels inconsistent because the system prioritizes access and capability over simplicity. Hospitals are not selling identical products. They are maintaining complex environments designed to respond to uncertainty. And uncertainty resists standard pricing. Understanding that doesn't eliminate frustration. But it explains why two hospitals, even neighbors, can arrive at very different numbers for the same care. And once you understand the structure, the variation starts to make sense.